Acid-base imbalances are problems of acid-base balance resulting from changes in the blood hydrogen ion level or pH. Imbalances in which the blood pH is below normal reflect acidosis. In acidosis, the acid-base balance in the blood and other extracellular fluid is upset by excess hydrogen ions, and you will see an arterial blood gas below 7.35. So you got to remember again that hydrogen ions and pH are inversely related, they're opposites. So when one goes up, the other goes down. In this case, excess hydrogen ions, an increase in hydrogen ions, causes a decrease in blood pH, and the normal being 7.35 to 7.45, so we would see a pH below 7.35. Acidosis, whether it's a metabolic or a respiratory acidosis, is caused by an increase of hydrogen ions. So regardless of whether it's caused by an overproduction of hydrogen ions or an underelimination, both of these scenarios create excess hydrogen ions, which lead to acidosis. Another way that we can have a buildup of hydrogen ions is if bicarbs are being underproduced, because remember bicarbs will bring down hydrogen ions, or else over-eliminated. Overproduction of hydrogen ions can occur due to excessive oxidation of fatty acids, such as with DKA or starvation. Another cause of overproduction of hydrogen ions is hypermetabolism, and that can be seen with heavy exercise, seizure activity, fever, hypoxia, and ischemia. Finally, is excessive ingestion of acids, with alcohol intoxication or salicylate or aspirin intoxication or overdose, can also lead to overproduction of hydrogen ions. Under-elimination of hydrogen ions can be caused by kidney failure or lung problems. Underproduction of bicarb can also be caused by kidney failure, as well as pancreatitis, liver failure, and dehydration. And finally, over-elimination of bicarb, such as with diarrhea, can lead to an increase of hydrogen ions. And the way that I remember that diarrhea causes acidosis is I remember that I lose bases out my bum. Losing bases out my bum would cause an acidosis. Other people remember, they think of the ass of acidosis, which is a little much, but it helps you remember, right? Acidosis with diarrhea. And here's some lab values for metabolic acidosis. And next week we'll do some activities to help you analyze lab values to figure out if it's acidosis, alkalosis, metabolic, or respiratory. But in general for you for this week, in terms of studying, you should know that metabolic acidosis, one, it's acidotic acidosis, so we're dealing with a pH less than 7.35. Since it's metabolic, we're really going to focus on this bicarb. So the bicarbonate being less than 21 in a metabolic acidosis. Oxygen normal, CO2 pretty normal, and serum potassium is high. Another type of acidosis is respiratory acidosis, and this results when respiratory function is impaired and the exchange of oxygen and CO2 is reduced. This problem causes CO2 retention, which leads to increase in the hydrogen ion levels and acidosis. So some things that can cause retention of CO2 include respiratory depression, inadequate chest expansion, and again, respiratory depression can be caused by anesthetics, opioids, electrolyte imbalances. Inadequate chest expansion can be caused by muscle weakness. Airway obstruction is another cause, as well as alveolar capillary block. The hallmark of respiratory acidosis is a decreased concentration of oxygen in that arterial blood with rising carbon dioxide levels. In terms of lab values for respiratory acidosis, we're talking about acidosis, so the pH is less than 7.35. The PaO2 would be low. Remember, we're talking about impaired gas exchange. So normally we want our PaO2, do you remember what our normal levels are? Normally we want our PaO2 between 80 to 100, right? So our PaO2 would be low. Our PaCO2 would be high. Bicarb will vary. Serum potassium would be elevated with acute acidosis and normal to low if compensation has occurred. In general, you want to associate acidosis with high levels of potassium. We just want to note a person can have combined metabolic and respiratory acidosis. Think about a patient with COPD who develops DKA. In terms of assessment and noticing, we're going to talk about what you're going to see in your patient with acidosis. And the tip that I've gotten somewhere along the way is that whatever the pH is doing, that's what the body is doing. So with acidosis, is my pH going up or down? Acidosis, my pH is becoming less, it's going down. So with acidosis, the signs and symptoms you'd see in your patient is as if their body system is being turned down. So let's look here at some of the signs and symptoms. And these signs and symptoms of acidosis are the same regardless if the cause is metabolic or respiratory. We'll start with cardio here. So cardio changes that you would see include delayed electrical conduction. So again, turning down, slowing down electrical conduction of the heart. Hypotension, turning down the blood pressure. Thready peripheral pulses, so a weak peripheral pulse. Central nervous system changes include depressed activity, lethargy, confusion, stupor, coma. So the central nervous system being turned down. Neuromuscular signs and symptoms include hyporeflexia, so decreased decreased reflexes. Also, skeletal muscle weakness, the strength of those muscles getting turned down, and flaccid paralysis. In terms of respiratory, when you're looking at scenarios and the respiratory rate gets thrown in there, you have to look at the scenario to understand, is my initial problem a respiratory problem, or am I looking at a respiratory compensation, right? Because with acidosis, the increased rate and depth of respiration with Kussmaul respirations is a compensatory mechanism to try and get the pH back up and decrease the hydrogen ion concentration in the blood. Skin changes. Warm, flushed, dry skin in metabolic acidosis, and pale to cyanotic and dry skin in respiratory acidosis. So the rule of thumb for signs and symptoms is however the pH is going, that's how your body systems are going. If my pH is going down as within acidosis or as with acidosis, all my body systems are going to be turned down also. When talking about respiratory acidosis, what's the priority problem for the patient? Reduce gas exchange. In terms of responding, how are we going to fix the problem? Interventions for acidosis focus on correcting the underlying problem and monitoring for changes. We talked about a handful of different things that can cause acidosis. So the treatment is really directed at what was causing the problem that led to acidosis. Interventions for metabolic acidosis include hydration and drugs or treatments to control the problem causing acidosis. For example, if the patient is suffering from DKA, insulin would be given to correct the hyperglycemia and halt the production of ketone bodies. If the patient is having diarrhea, remember bases out the bum, so they're having a metabolic acidosis. Rehydration and anti-diarrheal drugs are given if the diarrhea is prolonged. Bicarb can be administered. You're usually going to see that if pH levels are less than 7.2. Nursing priorities include continuously monitoring the patient to see that they're responding to treatment or note if they're becoming any worse. Cardiovascular and skeletal muscle systems are sensitive to acidosis and are the most important systems to monitor. So really monitoring skeletal muscle systems as well as cardiovascular systems. And another thing that we're going to be monitoring or interpreting are those ABGs. Monitoring those is an important thing to be doing. If the patient is experiencing respiratory acidosis, treatment will focus on improving gas exchange. Treatment could be drug therapy, oxygen therapy, pulmonary hygiene, which includes positioning and breathing techniques, as well as ventilatory support. Drug therapy that can help improve gas exchange includes bronchodilators, anti-inflammatories, and mucolytics. Oxygen therapy helps promote gas exchange for patients who are experiencing respiratory acidosis. I want to carefully monitor oxygen saturation to ensure that the lowest flow of oxygen needed is used. Ventilatory support with mechanical ventilation can be used if necessary. And nursing priorities in terms of preventing complication is we want to monitor the patient's respiratory status, monitor breathing, respiratory rate and depth, listen to breath sounds, check for any retractions or use of accessory muscles, or whether the patient is grunting or wheezing while breathing. We will also want to assess nail beds and oral membranes for cyanosis, which is a late finding of hypoxia. Even when the underlying disease process is well managed, sometimes the patient isn't always back to 100%, but indications that a patient's respiratory acidosis is being corrected is if the patient is able to maintain adequate gas exchange with arterial pH moving closer to that 7.35, which is the normal on the low end. Also that the patient has a PaO2 level of 90 or at least 10 millimeters of mercury higher than their admission level. So we're showing improvement. So if we're not at 90, at least we're getting better. Also, the patient has a PaCO2 of less than 45 or at least 15 millimeters of mercury below his or her admission level.